Good morning. My name is Feroz Mahmood, and I'm the Division Chief of Cardiac Anesthesia at Beth Israel Deaconess Medical Center in Boston. And today we're going to be talking about the transcatheter edge-to-edge mitral valve repair, the current status, and future directions. These are my disclosures. I am a consultant for Abbott Medical Systems as well as GE Ultrasound, and we also have a YouTube channel, which is a free educational resource created by cardiac anesthesia faculty of our division. I highly encourage you all to go there and take a look at all the videos that we've created. This is good for residents and fellows. Having said this thing, let's get back to the edge-to-edge repair. So in a nutshell, edge-to-edge repair consists of bringing both the edges of the mitral valve, that is the anterior and posterior leaflet, together and tying them up in the middle. Now this was traditionally done with surgery, but now this is being done with the transcatheter approaches, and that's exactly why we are here. And at the end of the day, when this happens, this valve gets converted into a double orifice valve. It is clipped from the anterior leaflet. This is the anterior leaflet which gets clipped to the posterior leaflet, and that's what makes it a double orifice valve, and that's called an edge-to-edge repair. And most of the time, this is best for lesions in the center of the valve. That's why that is called the A2 and P2 region of the valve, which is most easily achievable target, easily acquirable target, and therefore lesions both in the middle of the valve are very easily treated with transcatheter approaches. Now, the outline of the talk is very simple. First and foremost, we're going to go over the scope of the problem, which is, what are we trying to achieve with transcatheter therapy. Later on, we're going to go over certain, technologies, that is both the Mitral clip as well as the Pascal device. Then we'll go over the evidence or the lack of it or whatever there is out there available right now as far as evidence is concerned. And lastly, we'll go over the procedure and guidance, which is one of the most important parts that we are here for. Now, let's see what is the actual problem. The problem that we are trying to treat with transcatheter therapy is mitral regurgitation. Now, mitral regurgitation is not a trivial problem. This is a statistic from American Heart Association which says that majority of the valvular disorders increase with age in generally, but specifically so mitral valve kind of exponentially gets involved in disease processes leading to mitral regurgitation after 70 years of age. So this is not a minor problem, it's a pretty significant public health problem. And the reason that it is not paid that much attention to, because there aren't much therapies available, and it is significantly overshadowed by aortic valve because the availability of open as well as transcatheter therapies for the last many decades. However, it is, besides being very prevalent, is also not a benign disorder. Increasing MR leads to increasing stress, muscle loss, LV dysfunction, and finally LV dilation, and then you get into the vicious cycle of progressive more mitral regurgitation. So that is one of the most important reasons that if left untreated, this can lead to about 57% mortality if you do not treat these patients. Now, we'll be using these terms quite frequently, so let me explain those. They are primary mitral regurgitation and secondary mitral regurgitation. We'll be using these terms a lot in the due course of time. So the most important one is primary mitral regurgitation, which is mitral regurgitation because of primary abnormality of the valve. As you can see in this one, there is this prolapse of the posterior leaflet, and there's an actual structural abnormality of the valve. Secondary mitral regurgitation refers to mitral regurgitation in the absence of any structural abnormality of the valve. This is a disease processes in which the mitral valve is an innocent bystander and ends up being dysfunctional, leading to mitral regurgitation. So keep these two terms in mind, that is primary mitral regurgitation as well as secondary mitral regurgitation, because the entire transcatheter therapy is somewhat designed around these things. So the dilemma over here is that primary mitral regurgitation, as you can see in this situation, there's the three-dimensional image of the mitral valve. This is the posterior scallop, and you can see a lot of torn chordae. So this is primary mitral regurgitation. This is a very frequently performed operation as an isolated procedure, and a lot of patients get primary mitral valve repair when they only have this problem. However, secondary mitral regurgitation, which is more pathologic than primary mitral regurgitation, leads to more outcome, is mostly performed only as an adjunct procedure and not as a primary procedure. You go in for cardiac surgery for some other procedure, you have mitral regurgitation, and therefore you get a mitral valve procedure, but you rarely go in specifically for secondary mitral regurgitation. Now, in addition to this thing, this is also a very important statistics that because of all the the comorbidities that patients have in these regions, only about 2% of the patients who have mitral regurgitation actually get referred for cardiac surgery. So there's about 98% of the patients who either get guideline-directed medical therapy or no therapy at all, and eventually die because of this problem, because there's no such therapy available for them. So what do we need to do when we get to this point? And that is, we need to provide a solution, that is to have a mitral valve which is diastolically non-restrictive and is systolically competent in a process which is of minimal risk and does not add to the risk of the patients who are already have so many other comorbidities and are considered prohibitive risk for surgery. So now, where did this technology and idea come from? First, let's go over the surgical mitral valve repair. That's Dr. Alain Carpentier from France, who kind of is the pioneer of different mitral valve techniques, and his techniques consisted of resection of leaflets, doing some very complicated repairs, annuloplasty devices, and then providing apposition of the mitral leaflet between anterior and posterior so that they oppose each other and there's no mitral regurgitation. In contrast to that, Dr. Ottavio Alfieri, who's an Italian surgeon, forwarded the idea of tying the anterior and the posterior leaflets together, which is referred to as an Alfieri stitch, to restrict the motion of the valve and prevent significant mitral regurgitation in the mid-1990s. I mean, when he proposed this idea, he did hypothesize that it could be possible in the due course of time to do this process percutaneously. Having said this thing, so this idea was being worked at for a long period of time. There's this company, eValve from California, that had been working on developing a stitch that could be done percutaneously to tie both anterior and posterior leaflets. However, the moment of epiphany was when Dr. St. Gore from UCLA got involved into it and designed and showed them the drawings of their mechanical device that could be used to clip the mitral valve. So Dr. Gore was the person who actually changed the idea from a stitch to an actual mechanical device to clip the mitral valves and bring them together. And as a result of his drawings, this is exactly what was created. This is the gripper arms. These are the grippers. These are the threads that are used to, grab the mitral leaflets, as we'll go in the next drawing, we'll see that, and then finally close this together. So this is the gripper. This is the gripper arm. The mitral valves are grabbed between the gripper arms and the gripper. They're closed down, and then finally the clip is brought together to close. So this was essentially the idea. The major difference between the easier surgical stitch, which was a very simple idea to go and stitch it percutaneously, and the mitral clip device that was designed, was the ability to reverse until you get deployed completely and to assess the design or the result of the application in real time using transesophageal echo. So that was the major difference between a surgical stitch applied percutaneously, which is a very easy process to do, and contrast that with mitral clip, which was much more complicated device, but it could be retrieved and redeployed. The results could be assessed, and therefore in real time all these changes could be made, where a stitch was a one and done kind of a situation. So in 2003, the first patient, Octalina Mendoza with a P2 flail, was the first one who underwent a mitral clip procedure for a P2 flail. She did very well. Excuse me, she's still alive, and that was heralded the start of percutaneous edge-to-edge repair. Now, what ended up was this device, which is, applied percutaneously, goes into the left side of the heart, and this is this contraption which stays outside the patient, and these knobs are used to guide the mitral clip in different positions and different directions in the heart that we'll go over to see how it is done. Now, the clip has, over the years since its inception, from 2003 onward, has gone multiple iterations, and now we are into the generation 4 of the clip. Now, this is truly a technological marvel. We'll go over the different designs and the dimensions of it. So there are two versions, that is the generation 4 NT and XTs. XTs are 12 millimeters clip arms. This is about 9 millimeters. This grabs about 17 millimeters of a flail gap between leaflets at about 120 degrees, and that does 22 millimeters. So really, depending on how much leaflet you have available, what's the flail gap, you have an array of clips that you can choose between the two of them. However, one of the most important one of the most important technological advances was ability to grasp each leaflet separately, because the prior generation of mitral clips had the had a design where both leaflets were grasped simultaneously and then brought together, which was sort of a problem with patients who had arrhythmias, patients who were tachycardic, and you had to time it absolutely correctly, and sometimes even use adenosine to induce a transient cardiac arrest to grab the leaflets. However, with the ability to grasp them individually has done kind of wonders, and we do it some complicated, challenging cases also. Now, if you look at the two different kinds of clips, they have the clip length, the arm length, the gripper length, and the friction elements. These are the ones that you use. However, the more important, bigger differences are the clip arm length is 9 millimeter. This is 12 millimeter. The flail gap that they can address is about 17 for the N types, 22 millimeters for the X types, and the N type W types are about 2 millimeters wider than the non-W version. So this is beyond the scope of this presentation right now to go over the specific details, the kind of lesions that it will be done. But we have now two choices in generation 4 clips. Now, while this was going on in about 2017 and 18, came another player in the town, and that's the Pascal precision system by Edwards. As you can see from its design, that it is pretty much based on the same principles of having the ability to change the position and the orientation of the device in the intracardiac space. And they had similarly a catheter steerable guide sheath that went through the femoral vein into the IVC, into the heart, and then they had a clipping device at the edge of it. What it is referred to as is a Pascal rather than a Mitra clip. The change in terminology, they call them clasps as opposed to grippers, and the arms are called paddles. The major difference is that they have a spacer in the middle, and that is the key difference, that this spacer, according to them, and as well as over here, gives them the ability to grasp the leaflets and not generate that much tension, reduce mitral regurgitation, but since it's not pulling on them that hard to bring them together, so there's less tension. But these are all manufacturer claims, never been tested, but essentially the principles are the same of bringing the leaflets between the clasps and the paddles, closing them, and then finally closing it together. Now, the difference between the Mitra clip and the Pascal precision systems are multiple. While they have 4 versions for the Mitra clip, there's only 2, the P10 and the ACE1. The major difference is that Mitra clip is made up of a cobalt chromium alloy, whereas Pascal device is flexible arms and nitinol covered with fabric. The closure for Mitra clip is active, which means you tighten it up, whereas the Pascal precision system maintains its memory based on the deformation, and the number of active locking elements are 2 and 3 in them, but pretty much by and large the clipping mechanism is essentially the same, or the edge to edge is the same. Now let's go over what the evidence states for these devices. This is a very important part. So let me get to the major part of it. Is the first implant, as you can see, was implanted in 2003. After this was the Everest trial, which was conducted entirely in Europe, just consisted of 55 patients, and demonstrated the feasibility of doing Mitra clip in these patients. The next one was a randomized controlled trial between surgery as well as a Mitra clip and guideline and therapy, which demonstrated the safety and the comparability of Mitra clip with the surgical repairs of the mitral valve. So the majority of the recurrences of them are with Mitra clip in the first year. If you go beyond the first year, this demonstrated that it was pretty much as good as surgery. Then there were multiple trials, which the high-risk study, the Access Europe study, but all that led to a CE mark, which is kind of the FDA approval in Europe in 2008, followed by availability of USA in 2013, and then started the major trial, the COAP trial, which we'll discuss in just about a second. And the device was approved by the FDA in 2013 for primary MR and 2016 for secondary MR. Now, the first major trial was a COAP trial. We'll go over the numbers in these patients and everything. But this demonstrated that the patients with heart failure and moderate to severe secondary mitral regurgitation, not primary, there was a lower rate of hospitalization of heart failure and lower all-cause mortality within 24 months. So in bottom line, the COAP trial that was published in 2018 demonstrated benefit of mitral valve in patients with secondary MR at about 24 months. Now, those great results. However, the problem was that simultaneously a Mitra FR trial was going on in France, which demonstrated at 12 months no benefit of FMR in patients. Now, this was kind of a very disconcerting, because these are well-designed, similar trials coming to exactly opposite conclusions. Now, as you can see in the COAP trial, there was a significant difference between the device group as opposed to the patients with secondary mitral regurgitation who had maximal guideline-directed therapy. So it demonstrated that patients with guideline medical-directed therapy and CLIP do better than the ones who had guideline-directed medical therapy. As opposed to that, the Mitra FR trial did not demonstrate any of these things. So this was a pretty complicated affair in how to reconcile with these things. Now, as you can see, there were significant differences between the two trials. One of the most important ones, that the COAP trial, which demonstrated the benefit of MitraClip, was funded by Abbott, whereas the mitral FR trial was funded by the French government. The patients in the COAP trial had smaller left ventricular end diastolic volume, which is kind of a very important thing, which we need to reconcile, and we'll find that out later on. They had more mitral regurgitation, which is counterintuitive, but they still did better. They had, there were minor differences in the guideline-directed medical therapy and inclusion and exclusion criteria, but none of them was big enough to demonstrate or to get these trials to end up at exactly opposite directions of the decision. So they came up with some very good reasons. For example, in the maximal directed therapy that was required in the COAP trial, but was site managed and less aggressive in the Mitra FR trial, which meant maybe these patients were less optimized in the FR trial. That's why they didn't better. Also, more residual MR was seen in the mitral FR trial at 1 year as compared to the COAP trial, which meant not only they were less optimized, but also ended up having more MR was tolerated in these patients. However, one of the most important things that was not initially seen, but later on brought up, was the fact that the mitral FR trial enrolled patients with larger left ventricular end diastolic volumes. Now, this is a very important thing, and that brought in theoretical mathematical explanation to reconciliate these opposite results, and that is the concept of proportionate and disproportionate MR. While it's a lot of mathematics over here, but try to simplify for all of you, which implied that in the Mitra FR trial, which you see up here, the patients had large left ventricles, which means the severity of MR was proportionate to the left ventricular dysfunction. So all of them had proportionate mitral regurgitation. As opposed to that, the patients in the COAP trial had smaller left ventricular volumes, which means their mitral regurgitation was disproportionate to the severity of the LV dysfunction, which means the LVs were not that bad, and the leaflets had something to contribute to mitral regurgitation, and therefore, when we did an edge-to-edge repair, they did better. So therefore, patients who have disproportionate MR, which means part of the reason for mitral regurgitation is the leaflet problems, actually did better with MitraClip, as opposed to the Mitra FR trial, in which the LVs were very large and they had proportional mitral regurgitation, and even if you did anything to the leaflets, that wouldn't do anything at all to the outcome. So that's why they had not as great an outcome as patients in the COAP trial. So this was an accepted reason, a very fancy mathematical retrospective application of a concept which has never been tested prospectively, but the FDA accepted it and it was approved. So as a result of this thing, now we have this guideline kind of situation. So which means if you have symptomatic primary MR, that is, you have mitral regurgitation which is due to a structural abnormality of the valve, you are eligible for surgery only if you are inoperable or prohibitive risk for surgery. And if you have symptomatic severe secondary MR, which means you do not have any structural abnormality of the valve, and you are COAP-like patient, which means you have disproportionate mitral regurgitation, then you are a great candidate for edge-to-edge therapy. And if you're non-COAP-like, then you have other options, which means you have proportionate MR, then you should have LVAD, a heart transplant, or surgical mitral valve. So this is where we stand with these situations. So what do we have achieved and what have we achieved so far? So that is that for indication for primary MR for edge-to-edge repair is only when you are a prohibitive risk for surgery, and secondary MR if you have your ideal candidate if you have disproportionate mitral regurgitation. Now comes the most important part, and that's the technique and procedural guidance in these patients. Now, imaging for structural heart disease is a new specialty. There's the challenges that has limited or no training, and it is still unsettled that who is best suited to do it, the cardiologist, the cardiac anesthesiologist, and it's a very complex process. In our medical center, we've had the privilege of having a structural heart disease fellowship for the last about 6 years, and we take very seriously of approaching training for this complex process. We pay a lot of attention on developing proficiency rather than expertise, and we think that the proficiency of performing an edge-to-edge repair is based on 3 components: procedural knowledge, workflow knowledge, as well as echocardiography skills. And that's called the workflow. You have to know each and every step of the process before you go on and do it independently. And that is individually established through observer metrics when we have these fellows work with us in these rooms. We believe in the Lego approach, which means a complex shape consists of multiple small pieces, which means a complex competency consists of multiple small simple competencies, and each of those competencies is equally important. A simple competence is as important as a complex competency, and you have to master each one of them before you graduate to the next stage. We have even published these results, and that is the divide and conquer approach, and we have this algorithmic approach on this one where fellows initially are involved in deliberate practice, as you can see in this one. They're initially involved in deliberate practice that they do in the simulation center, then they go through the observation phase, and then they have to know a very comprehensive knowledge of radiation safety, which I'll go in little detail and subject, which is very near and dear to me. Then they go and see the conduct of the hybrid operating room, knowledge of the integrative monitors, how to do it, image review with the experts before the procedure, and finally, when they have mastered each of these competencies, they get involved in the process of guiding an actual edge-to-edge intervention. So this is called a Lego and an approach and everything. So we have now divided our training into multiple processes, one of them being the logistics phase. We'll go each one of them. The prep phase, that is the preparatory phase before you go the imaging studies review. Then we go on to the procedure, which we have divided into the right side part of the procedure, that is the procedure in the right heart, and the procedure in the left heart. And once you get to the left heart, the process is above or below the mitral valve, and each one of them will be discussed shortly as we'll go along. So this is the modular phase which gradually goes from the right to the left side, and we get to that. And after we've deployed everything comes the post-deployment assessment of whether or not this procedure is a success. So this is a complete science in its own right, and we'll briefly touch on that subject as well here. So first is the logistics phase of the procedure, which consists of room setup, anesthesia equipment, imaging equipment, integrative imaging, and anticoagulation. And these are important aspects. We've had processes in which right in the middle of the procedure, when we started 3D imaging, found that the 3D probe was not working. That added about a couple of hours to the procedure. So this is the duty of the structural heart disease fellow to see that the room, besides being the setup for anesthesia, the anesthesia equipment is perfectly fine. The image equipment is functional, is 3D capable, and can generate those 3D imaging. All the monitors are available, because unless the cardiologists see a 3D image, they cannot actually perform this procedure. And finally, the ability to anticoagulate or any peculiarities in the patient, HIT, heparin resistance, all that kind of stuff has to be factored in before you start this procedure. I'm sure you all have seen this hybrid operating room. You have a bunch of them in your medical center. We've just been blessed with about 6 of them. We do a lot of the stuff in our hybrid operating rooms. The key part in this one is this machine, which is the C-arm, which is a menacing looking, robot kind of a thing, which moves very fast, is very, very powerful. And I have myself been knocked out a couple of times with this machine and hurt myself on the knee. And the machine our ultrasound machines have multiple times been broken by simply the force and the speed of motion of this machine. So you got to keep in mind of these things, Now this is an important diagram, and keep an eye on this one. You look at the anesthesiologist. I would look at the position of the echocardiographer in relation to the C-arm, and the mobile equipment. This is a critical piece which is just being recently recognized, the proximity of the echocardiographer to the X-ray systems, because this is it has a lot of health hazards associated with this. So there's a bunch of articles on this one, but this is one of the most recent one, which goes over the fact that the exposure of radiation to the echocardiographers is multiple folds as compared to the interventionalists. And they're even better protected with these lead aprons under the table and everything, and we are not. So myself, I have developed early radiation-induced cataract, radiation-induced thyroiditis, which I thought was anaplastic cancer. And at the same time, I've had osteoarthritis of my metacarpophalangeal joints, so my hands being in the C-arm, having done over 1,000 mitra clips and things like this. So this is not an easy or not a simple undertaking. So you have to be very careful in protecting ourselves from radiation, having a detailed and a specific knowledge of this thing. The hybrid operating room is a shared space. It's stranger than the main operating rooms. There's cardiologists, there's monitors all over, cables hanging out over there. And as big as the room may be, as you can see, but the anesthesia equipment is all concentrated in one corner, and you are aware of this limitation because the rooms are designed not for us, but for the imagers. So therefore, or the interventionalists, so therefore, you have to be very efficient in how you do things and where you put these things on. I have no specific, predilection for any echo equipment. We have Siemens, we have GE, Philips equipment. We can use any one of them, but it has to be capable of three-dimensional imaging. You have to have heparin, propofol, protamine, a lot of pumps, and above all, the ability to cardiovert and defibrillate the patient. And we, as a protocol, apply these pads before we start, because the chances of either arrhythmias or ventricular fibrillation is a lot because of all these moving catheters, and therefore we use that in the fashion. At the same time, we have to have propofol infusion, because in the middle of the procedure we convert into a total intravenous anesthesia when the patient becomes apneic. We have invasive monitoring lines, particularly A-line. We run an ACT between 250 and 300, doing an ACT about every 15 or 20 minutes. That's the protocol. Now comes the most important, is the prep phase. That consists of imaging studies review, history and physical of the patient, imaging strategy, transseptal puncture and clip review, which side, how many clips, the location, presence of calcification, leaflet lengths. All these things have to be done in a heart teams meeting that is done a day before the actual clip. And finally, imaging practice. So the questions to be ordered in this prep phase are: type of mitral regurgitation, is it primary or is it secondary? Severity assessment, the status of the mitral valve apparatus, that's a detailed knowledge and a complete science in its own right. And finally, any contraindications, more specifically, the presence of mitral regurgitation has to be excluded. Then, just because you've been doing imaging for cardiac surgery doesn't mean you're good for structural heart disease imaging. There are significant differences. Cardiac surgical imaging is comprehensive. This is focused. This is intermittent. This is continuous. This is before and after bypass. This is synchronous with the procedure. This is before and after anticoagulation. That is during anticoagulation. So therefore, there are more complications that have been reported with the imaging for structural heart disease. And above all, in cardiac surgery, you interpret the image, the intervention is performed, and then you reinterpret it. Whereas in structural heart disease imaging, you are continuously interpreting as a point of care fashion. So that's one of the most important things. If you keep going on it, most of the time is spent in this image. This is a 3D image of the mitral valve that demonstrates the aortic valve at 12 o'clock position, the left atrial appendage at 9 o'clock position. And this is the anterolateral commissure, and that is the posteromedial commissure right over there. So we look at this image in the graphic. The portion towards the aortic valve is the anterior portion. The below is the inferior portion. Lateral is to the left atrial appendage side, and the other is the medial portion of the valve. So imaging for structural heart disease is important in the sense that we have to know the patient's specific anatomical peculiarities. Majority of the old patients with kyphosis and scoliosis, and so we have to know any specific imaging limitations, imaging windows that are available, and above all, esophageal pathologies. Like I said, these are patients in later years of their life. A lot of them have, undiagnosed esophageal pathologies, and this can lead to, a lot of esophageal injuries, which has shown in studies is many times more common than imaging for structural heart disease. for transseptal puncture, which forms the basis of all this procedure, is something that we take very seriously. Again, we break down this complex process into a very simple process of doing multiple things. We call it the Pitlock protocol, which is based on the practice, identify, track, locate, optimize, and cross. And as you can see, this transseptal, interatrial septum, while it's a small structure, but when it comes to doing, a very precise puncture, it's a huge landscape. And you have to be very precise and specific in where you are approaching the septum. Majority of the time, we consider these four views of the interatrial septum, which is superior, inferior, that is anterior, posterior, low, and high. And we'll go over each of these images in a second. As you can see in this specific graphic, when you look at these images, the superior image is in relation to, sorry about that, So the superior image is in relation to the superior vena cava. That's the inferior margin of the fossa ovalis. That's the anterior margin related to the aortic valve. And then we have the posterior margin that we look at in the mid-esophageal four-chamber view. So these are kind of the four margins of the interatrial septum that we need to display for our cardiologist to look at it. So superiorly, we have the SVC here and the IVCs, that are the superior and inferior. And over there, we have the aortic valve, which demonstrates the anterior, and then we have the posterior margin right next to it. So in this video, you can see that in the upper video left over here, we have identified and we tracked the transseptal puncture needle to the fossa ovalis. We have tented and located it. We are using the 3D markers to optimize our after septal puncture, and then we finally cross it in 3D in exactly the location that we want it to. So this is essentially the entire Pitlock protocol in 4 images. You can see how we specifically, the fellow has to do each one of these procedures. As far as the procedural phase, both the left side above and below this thing, I've had the privilege of quarterbacking this article, which was published in JACE in 2018 about the workflow of a edge-to-edge repair, a good resource for all those who are interested in pursuing this specialty. So once you've crossed the interatrial septum, now we're on the left side of the heart. One of the most important things to recognize is the Coumadin ridge, or the ridge between the left atrial appendage and the left upper pulmonary vein. Left atrial appendage is one of the most anterior structures, the thinnest portion of the heart, and anything going into the left atrial appendage is a high likelihood of rupturing it and causing a effusion and pericardial tamponade. So this is one place that you do not want to go. Identify the Coumadin ridge and park everything, every catheter that comes into it, into the left upper pulmonary vein. Because in this entire parking lot, this is a safe, known parking spot where you can park the catheters before we start moving. It's a good reference point to start moving your catheters in a very dilated, large left atrium. For example, in this video, you can see right over here is the left Coumadin ridge, left upper pulmonary vein, left atrial appendage. And in this graphic, you can see that the catheter is parked in the left upper pulmonary vein. The procedure is pulling it back over the Coumadin ridge into the left atrium and avoiding the left atrial appendage and going right over. See that moment they crossed over, this Coumadin ridge went into the cavity of the left atrium right over here, and now they will straighten it, avoiding the left atrial appendage here, right here, and going it over the mitral valve. So that's the process of doing this thing. Now once the device is in the left atrium, now the fun starts. Now the element of precision and guidance starts very well, and we'll go over this one. So we look at again, an en-face view of the mitral valve with the aortic valve at 12 o'clock, tricuspid valve, left atrial appendage at left atrial appendage over here at about 3 o'clock, and the coronary sinus. And also the position of these objects is also viewed from en-face in a clock view. And if you look at it, aortic valve is at 12 o'clock, left atrial appendage is at 9 o'clock, the interatrial septum is between 1 and 3 o'clock, and this is how we guide and orient the mitral clip when we go along over here. So this is how it is. The aortic valve is at 12 o'clock position. You can see right here. The atrial appendage is at 9 o'clock. This is the posteromedial commissure. This is posterior. This is anterior. And remember, we said this is the center portion of the valve, the more important, where majority of the action happens. So another important reason is that both the posteromedial as well as the anterolateral commissures of the mitral valve are very rich in chordae tendineae. And you want to adjust the position of the clip from medial to lateral above the valve. You don't want to go below the valve and move medial to lateral because you'll be moving orthogonal to these chordae tendineae, and there's a high likelihood of getting caught in there. So these are very rich in chordae tendineae, and that's the place you want to avoid in a simple mitral clipping, because well, we often have mitral clips deployed in these, but they are very high risk procedures, require an utmost amount of experience and imaging in doing those procedures. So again, take a look at it. This is a very important point, that both the posteromedial and the anterolateral commissures are very rich in these chordae tendineae, and if you want to move from left and right, from medial to lateral, this has to be done in above the mitral valve and not below it. So end point of guidance is to be able to deploy a clip which is, or an edge to a device which is orthogonal to the point to line of coaptation and grasp both the leaflets. That's the end point. Right when this is about to do it, since it is such a matter of precision that to account for the translation motion and respiratory motion of the heart, we induce long periods of apnea for position of the device. At that moment in time, you have to have propofol infusion, a total intravenous anesthesia, and have the patient passive oxygenation with 100% oxygen, high flow oxygen, so that they maintain their saturation. It can become complicated and difficult at times when you're trying to do something like this. Now, the guidance of the device, the major principle is like guiding a blindfolded person in a room to a certain specific target. When they're blindfolded, it does of no value to telling them where they are. More important is where they want to go. That is a more valuable information. You want to go left, right, front, backwards. Just telling them you are at this location to a person who cannot appreciate the X, Y, and Z axis is no information. For example, if step one in this situation would be to identify the target. Looking at this mitral valve, we identify the target between A2P2 and A3P3, and then we guide them to this location. Now, in this specific situation, you can see that the clip is very anterior. It is above the line of coaptation into the anterior valve. Take a look at it. This is the target. This is where the clip is. And if you look at it on the valve, this is the center portion. So if you want to tell them where to go in relation to the target, the correct guidance would be that you need to go, if I would need to make myself smaller to show you that you need to tell them to go posterior and medial to the point of target to get over there. In a similar situation, we can also use live three-dimensional imaging with the clip being shown up top and two-dimensional imaging at the same time to give them a better visual feedback from both 2D and 3D to guide the clip into the position. Another complicated situation, you can see over here that the clip is very anterior. We've identified the target slightly medial to A2P2, however the clip is very anterior and also is rotated a little bit clockwise. So the true guidance in this one, we rotate the clip clockwise 5 degrees, move posteriorly, and move medially to the point of target. So that would be the way we provide guidance and being very specific in our communication what we want. And if you want to look at it in real time, you see the clip is very anterior. We are telling them to rotate it counterclockwise, move posteriorly, and move medially. And as you can see in this real time, this clip is moving to the exact target that we wanted it to be. Once you have identified a location that you are above the valve and in the right location, then you cross from up top into the bottom. As you can see here, that the clip is crossing and going below. This is done in real time to show that you do not drift medially or laterally. Then the clip arms are open, and then you want to demonstrate the presence of leaflets in the groove between the gripper arms and the sheath. Then you drop the grippers to demonstrate the motion of the grippers or the motion of the leaflets to say that they're in the right location. Before you, this is what you're showing, and then you close it under color guidance to see that as you're closing and doing an edge-to-edge repair, bringing the leaflet edges together, there's less mitral regurgitation. To show you a clinical case, I will make myself smaller just to make a point here. So this is a patient, if you see aortic valve is over here, left atrial appendage is here, and this is the flail segment. So this is an A1 flail. We did a rather posterior and inferior transeptal puncture. We guided it with the precision. We got into a target position. And now, as you can see, that the target is at A1P1, where the clip is almost parallel to the line of coaptation. Now we want to ask them to move a little bit, rotate clockwise, move anteriorly, and a little bit more medially. And they are doing it as we look along. Now, as you can see, they've straightened the clip, but you can see that there's still some, the flail segment can be seen right below the clip. So it's not exactly on top of that segment. They have moved a little bit now, straightened it completely orthogonal to the line of coaptation, but still not over the clip. Now you can see it better that they're moving the clip a little bit more medially. They have closed the clip, going to about cross and become apneic, but you see as the patient became apneic, it has drifted a little bit more medially. Now we are trying to correct it and move it more laterally over A1P1. Once we confirm that we are A1P1, then we use simultaneous orthogonal plane imaging with 2D to confirm the position of the clip. And now we are exactly on top of the target where we need to be. We cross there. We are below the valve. Next, you see the leaflets, the graspers are opened. The leaflets are caught between the graspers and the arms, and then they will be closed after that. And as they are closed, there's less mitral regurgitation. Now, as you can see in this specific, we also confirm this position with 3D imaging to see that the clip is located in the right place and at the target where we wanted it to be. Now, the key part in this whole process is absence of mitral regurgitation has to be established after the application of clip before we do any other thing, because you could have a great grasp, you could get the leaflets very well, but still be at the wrong location and completely miss it and have significant residual regurgitation. So post-clipping, all of the assessments are done after we've ensured that there's significant reduction in MR, because if there's none, then we've obviously missed the target. For example, in this case, you can see that the patient has a flail P2. We apply a clip, optimize the clip, but there's still significant mitral regurgitation. So therefore, we ended up putting a second clip into this patient, which was a little lateral to the original clip. As you can see, this is the first clip right here. This is the second clip. And then once both clips are applied, the mitral regurgitation was significantly reduced to only trace severity. The protocol that we use after deployment of clip is called GLOW protocol. We use these kind of strange names just to make the fellows remember them. And the GLOW protocol is based on GLOW. G stands for grasping of the leaflets, the gradients, the leaflet target, whether we achieve it or not, orientation of the clip so that it is perfectly orthogonal, it is not oblique, so that we are kind of not torquing the valve, and finally the waves, and we'll discuss which waves. As you can see in this specific one, there's a clip has been applied, there's significant reduction in mitral regurgitation. However, if you take a look at it, there's a lot of motion of the posterior leaflet right where it enters the clip. This is exactly somewhere around here. You can see there's a lot of motion. Now contrast that to this clip here, which shows a very strong grasp, and there's essentially zero motion. Now the one before the one, which shows a lot of motion, means that the leaflet is not completely being grasped in between the grippers and the arms, and there's possibility that if the tension keeps coming up, that we're going to have a single leaflet detachment. So that's called the grasp of the leaflet. It's checking on how well in the case which is highlighted on the right side. This one we had to optimize the grasp of the posterior leaflet. Now the most important part of the gradients, that's the second part of G, is to avoid stenosis. Sometimes you can end up having high gradients, like in this one is 5.16 mean millimeters. We don't follow the peak because that majority of it is flow driven, so we follow mean gradients. However, gradients are pretty complicated, and they are a product of the cardiac output of that state, the heart rate, the anatomical orifice area, the left atrial compliance. So all these things have to be factored in before we call that this gradient is prohibitively high and we cannot accept this thing and we move on and do something. One of the most important things that we do is called the planimetry, that is using a three-dimensional echo to get both valve and actually planimeter both areas. So in this specific patient, the one that you saw which had a mean gradient about 5, when we planimetered both the areas, the total area of the mitral valve, as you can see, turned out to be more than 2 square centimeters. So that was good. So in that case, we identified that this is possibly related to flow, enhanced cardiac output, tachycardia. So that if we could ignore this thing, because the actual anatomical orifice area of the mitral valve is pretty significant. So then comes the leaflets and the targets. You want to show by 3-dimensional echocardiography that the target wasn't missed. And if you have grasp and there's significant reduction, that reduction in MR is not because the clip is still attached to the steerable sheath. And the moment you let the clip let go, there'll be significant mitral regurgitations. You got to be certain that this reduction in MR is not because you have applied the clip and you're holding it over there, and therefore there's no mitral regurgitation. So as soon as you let go and deploy the clip for permanently, there will be significant mitral regurgitation. And that's the point where you want to look at the leaflets that you have not missed your target. So that again, you use 2-dimensional echocardiography as well as 3-dimensional echocardiography to ensure that. One of the most important gratifying part is demonstration of reduction in MR through reversal of waves. Now, in severe mitral regurgitation, the regurgitation jet sometimes spills over into the pulmonary veins, leading to reversal of flow during systole. Every time there's systole, these waves are supposed to be positive, and these waves are negative, which means all that mitral regurgitation that is coming to the left atrium is spilling in the retrograde fashion to the pulmonary veins. And if it was severe MR, and if you put a clip in a good location and a good results, so this reversal gets is reversed and then becomes actual normal looking flow. And for example, in this one, you can see there's significant reversal, which turned out to be a positive flow. So this is one of the most gratifying results. Like in this patient, you can see there was a massive reversal on this side, as you can see in the left upper pulmonary vein, which after reduction application demonstrates there's no such reversal in there. So now there's evidence of these clips being done in emergency. There's growing evidence in literature in patients who are terminally ill with ruptured papillary muscles, other such problems, organ failures, who are too prohibitive risk for surgery. You can have a Hail Mary and do a mitral clip in these situations, and some of them do very well. As a matter of fact, in our own medical center, we've had 4 cases on intra-balloon pumps, multiple inotropes, multiple organ failures, who we did mitral clips or edge-to-edge repairs in an emergency, and fortunately all 4 survived. The intra balloon pumps were DC'd in the operating rooms. The inotropes were weaned and extubated within 24 hours, and all of them were discharged from the hospital. So at the end of the day, we looked at the extent of the problem that mitral regurgitation, particularly functional mitral regurgitation, is a significant public health problem with very few solutions, and edge-to-edge repair provides a very viable solution as opposed to surgery for these high-risk patients. The technology is evolving. It's likely to get even better over time. The procedure times are reducing. In our place, we do mitral clips in sometimes less than 30 minutes. There are currently 2 players in the market, but likely this number will increase and hopefully will be replaced by even better transcatheter mitral valves. The evidence is accumulating. It is definitive for functional mitral regurgitation. It is equivocal for primary mitral regurgitation. And finally, procedure and guidance. The major issue of procedure and guidance is the lack of training opportunities. However, the improving techniques, and we have shorter procedure times, but at the same time, the challenge is to find training opportunities and bring all the staff and fellows up to staff over here. Now, over time, as you've seen in our lifetime, the incisions have evolved from, sternotomies to mini sternotomies to substernotomies to endoscopic surgeries. Is that an evolution of incisions? But the percutaneous option to achieve all that without any incision is actually not an evolution, but a revolution in therapy for mitral valve disorders. Thank you very much, and I'll be taking any questions. Thanks.